All right, thank you guys for showing up. My name is Bilal Choudry. I'm an epileptologist and I work at the Neurology Center of Southern California, which is in the San Diego area. And been dealing with epilepsy patients for a long time and have a lot of experience with VNS as well. So today's talk is going to be on an introduction to VNS, and we're going to talk about the basics of drug resistance epilepsy, the chances of becoming seizure-free with medications, and VNS therapy, treatment for options for seizures that improve quality of life. Before we finish, we'll have an opportunity to answer questions and also share additional information if you guys need. About 3.4 million people in the United States have epilepsy, and it's really about 4 now, 4 million. So that's about 1% of the population. And about 35% of them remain drug resistant regardless of the seizure meds. So this number we get is from a trial that started in the 1980s up until the 2000s, where they went over different generations of epilepsy drugs and looked at seizure freedom rates in terms of patients who have epilepsy. And so in this trial, which was done in the University of Glasgow, so basically it looked at patients who had their first new onset seizure, and when they took the first appropriate seizure drug at the appropriate dose, about half of them, the high 40%, 47% or so, became seizure-free with that first medication. And then that second medication, it worked around 13 to 15% of the time to make them seizure-free. And then the third medication worked around 3 to 5% of the time to make them seizure-free within the trial. So from that, we got the diagnosis of intractable epilepsy. So if you ever see intractable epilepsy, it used to be failure of 3 meds, but now it's failure of 2 medications, because we know the chances of seizure freedom are going to be about 3 to 5% with meds at that point. So for those patients that are within the 35% range, that they've failed 2 medications or 2 plus, then we start thinking about surgical options. And in the epilepsy community, we try to target brain surgery first, because their chances of seizure freedom are 50 to 80%, depending on if you have a lesion, especially if you're closer to 80. And then if that is not an option, or the patient doesn't want that, then we have different options, and vagus nerve stimulation is one of those options that it should be highly considered. So vagus nerve stimulation was actually designed by, the vagus nerve itself was tested in the late 1800s by a physician, Dr. Coolidge, who felt that basically patients weren't getting enough blood flow to the head. And therefore he decided that he wanted to diminish blood flow by reducing blood flow to the carotid and also activating the vagus nerve. From that, it wasn't the best scientific idea, but from that we figured out that vagus nerve stimulation does help. And it's gone way far since then. And so it's usually an add-on therapy for young patients with partial onset seizures. So we don't use that terminology anymore. We use focal onset and or generalized. And so there's been more than 125,000 people who have used VNS worldwide, and 33,000 children. In the beginning, when I was first in my training, I was introduced to VNS, and I was kind of selecting it for special need kids and handicapped kids, and I noticed benefit from that. And in fact, I was getting rebound from them that, I'm scared that this kid is going to rip it out or do something, and that's never happened once. There's never been an issue. And then as I developed my career and I moved to San Diego, I was introduced to thousands of patients that were, candidates that really had been just sitting around and just doing one med after the other med, and some were on 4 or 5 meds. And as I introduced VNS, I started seeing dramatic changes. Some people who had never been seizure-free suddenly became seizure-free. I have one patient that was seizing, weekly and now is seizure-free. And other patients have had dramatic reduction in seizures. So I started suddenly just implanting a lot of patients and gaining a lot of experience. And really has been a game changer for a lot of patients. So the goal, however, I don't ever sell it as this is going to be a seizure-free kind of thing for you. It could be, but that's probably closer to 6 to 8% of people get seizure-free with VNS. So what I do tell patients is that when you first get vagus nerve stimulation, in the trials, they've shown that in the first 6 months, there's about a 41% reduction in seizures. In the first year, 50% reduction in seizures. Second year, 60%. By year 3, 4, 70% reduction in seizures. Patients have this, they have something called an autostim, which allows us to detect their heart rate. So 70% of the time when you have a seizure, your heart rate goes up. And with this, we did tests on patients in the epilepsy monitoring unit, and we figured out, even before the seizure starts clinically, that their heart is already racing, and then the seizure starts clinically. And so if we are able to tap into that and get it early on, then we prevented seizures or made them shorter 50% of the time. And so a lot of times what I'll do is I'll set that auto stimulation to 20%, meaning if your heart rate goes up just by 20%, and with seizures, we know that it just goes up quickly. While with exercise and other activity, it kind of has this kind of curve. Seizure has a quick curve. And so with that, even if I miss it, no big deal. I have some patients who are having 200 to 300 auto stimulations a day from their heart rate going up, and as long as it's not bothering them, it's not really affecting the battery life that much. And even if I can capture one seizure out of those 200 stims, that can be a big game changer for somebody. And so I always set the threshold really low for people to get that stimulation, because that allows me to capture the seizure at the very beginning, where sometimes there's not even a clinical change yet. And so that is one of the biggest changes, big game changer for this that VNS has done, is that it's allowed us to perhaps capture seizures. Because in the past, we would have a magnet where people would feel an aura, and an aura is a seizure, right? And so there's focal aware and focal unaware seizures. So if you have an episode of deja vu, that's a seizure. If you feel, a feeling of sense of rising sensation or doom, that's a seizure, if that happens right before your seizure. And so if you have that, then you can use the magnet and put it on your stimulator, on your generator for 2 seconds. So you say 1,000, 2,000, and you're done. And the magnet literally looks like my Apple Watch, right? And so you just go 1,000, 2,000, you're done. A caregiver who is there with you can actively participate and help stop the seizure. So even if you're not able to, let's say you're immobile, well, they can come and actively help stop the seizure. And 50% of the time in the trials, the seizure stopped and your seizure was shorter. So you have a faster recovery, you help stop the seizure. So it's almost as if you gave them a medication. And unlike a medication, you're not dealing with side effects of it. You're not drowsy, tired, out of it. There's no breathing issues. You're just doing it, and it'll last there for a minute. So you can't just do it 100 times. It's not going to make a difference. And after a minute, then you can try again if you need to, if it's a longer lasting seizure. So those two things on their own are big game changers, that not only is VNS used to prevent seizures, but you can actively participate in stopping it, and you, without even actively participating, it helps stop it on its own, even if you didn't have the capacity. Because in the past, I would have patients tell me, I don't have a warning, and I'm out of it, and there's no way I'll use a magnet. Well, now you have AutoStim, you don't have to use a magnet. So both ways, it's a preventative and an abortive device for seizures. So, is VNS right for you? In my mind, I think VNS is right for anybody who has intractable epilepsy, really. And if you fail 2 medications, you should seriously consider brain surgery as a workup. And if that's not an option, or you've done that already, then VNS is next. And the time that it takes to recover from seizures is interfering with their daily life. That's another thing, right? So people have this post-ictal state. They're tired, confused, out of it. Then using vagus nerve stimulation will dramatically improve that. Side effects from your current therapies, medications. We know that people with epilepsy, but according to data, 1/3 of people with epilepsy have problems with anxiety, depression. And a lot of this has to do with fear of having another one and not knowing when it's going to happen. Being fearful of going around into social environments where it suddenly may just happen. And then also the pathology of where it happens. And so we know that the number one area people have seizures is the temporal lobe, followed by the frontal lobe. And the temporal lobe, is where your memory is, right? Your hippocampus is within your temporal lobe. So that's where people keep memory. So that's why memory is often an issue with seizure patients. And it also is an emotional organ. So that feeling of doom or fear that happens is from the amygdala, which is embedded within your temporal lobe. And then you get into your frontal lobe, and that's where attention, focusing, and behavior is as well. And so we have 2 things going on. One, you're having abnormal electrical activity in areas that can affect your thinking and mood. And then you're having social issues with it, and in addition, potentially. And then even with that, epileptics, even if you go back to the antiquities, there's Aristotle, one of those guys, said epileptics are often melancholics and melancholics are often epileptics. And so it's common to get mood disorders with this. And so vagus nerve stimulation is indicated for depression. So I do have one patient that I treat, never had epilepsy. He just gets vagus nerve stimulation for his depression. So it's FDA approved for that. And also, and if you look at the trials, people had improved thinking, memory, performance, and mood, in addition to having much reduced seizures. So it wasn't just targeting seizures alone. So again, going over some of the benefits, there's certainly majority of patients have fewer seizures. If you look at some of their data, about 75% of people get reimplanted. And if I ask all of my colleagues, including myself, I would say most of us would say 95% of people get reimplanted. I've only had a couple of people say that it didn't help, and therefore I don't want it reimplanted. So depending on your battery life, which can last anywhere between 3 years to 10 years or plus, depending on what it is, you simply go and you replace the battery here. So after that time when your battery needs to be recharged. So there's certainly, again, I went over the quality of life improvements with mood, memory, attention, focusing. I've been telling some of my VNS patients off-label to even try to put the magnet on and read, or try to put the magnet on and learn something and see if it helps. Because we know there's now vagus nerve stimulation for strokes, where they help people recover from stroke when they stimulate it and try moving. and had more motor improvement. So, uh, and so, in their trials, in the past, Kaiser Hospital did a trial where they tried to see if this was going to be too costly for them or too costly for the patient. But there was actually dramatically less costs in your overall health care, and therefore it's always approved. So there was less hospitalizations, less need for meds, less need for monitoring, less everything across the board, less fractures, less risk of sudden death and sudden unexplained death in epilepsy patients, where patients sometimes will die from a seizure. So it reduced that risk. There was decreased seizure intensity, better recovery after a seizure, no medication side effects, and can be used with really any med. So there's no drug interactions. And you can still use it and still do other things in terms of surgeries, other surgeries you want. If you're still, aiming for seizure freedom, it doesn't preclude you from doing any epilepsy brain surgery otherwise. So I discussed some of the quality of life improvements there, and you notice that 38% of people had improved memory, 39% did more achievements, 45% increased their verbal skills, 49% had improved mood changes, 56 had less seizure clusters. And seizure cluster itself is just, did you have less seizures than you normally did? And 62% of people had improved post-ictal state, and 63% were more alert. Not too many I can't think of any seizure med that I gave you that says, by the way, you're going to be more alert, right? And this is probably one of the few. So VNS has been tested in kids extensively and is approved for people 4 years and older. And it's used in more than 35,000 kids worldwide, and offers long-term outcomes for children in critical times in their development, where we know when people have seizures that every seizure you have, it damages your neurons to a certain degree, right? And so that's why some people say after a seizure, I can't think it and I can't focus like I used to. Just that one seizure did it, one prolonged seizure especially. And so reducing the burden of seizures is really the name of the game, because if we don't, so let's say we just say, no, I'm not doing anything. I'm just going to let it roll, that the meds, we'll keep using meds. So seizures have something called a kindling response. So if you let seizures happen, so let's say, and I was told by this, by the head of Barrow Neural Institute a few years ago. He said a bunch of us epilepsy specialists were sitting at a table, and he said to young people, and I consider myself young, so I thought he was talking to me. He said, I do recommend one thing, and that is that for your patients who are saying, I'm just having an aura, I'm seizure free, I'm good. Don't let them say, I'm good, and treat them. Treat the auras. And even if the auras aren't messing with them, those auras, like I said earlier, are seizures. And if you don't treat those seizures, then basically he said that within 10 years, most of them will be convulsing, even if they've never convulsed, because you let those auras go on and on and on. And so that doesn't mean everybody's going to convulse. That was his opinion, but the main point is that the kindling response opens up new areas that become excitable. So even if you were just localized to one small area, now you have 2 areas potentially, or 3 areas. So you let the seizures become worse, and then they become more difficult to control. So if you try to nip them in the bud earlier, you prevent any spreading. You also prevent further neuron damage from seizures, because especially when you generalize and you have a seizure, then instead of just one area being damaged, now you have the whole brain being damaged. And so preventing someone from going into having a generalized seizure, is a big deal. We know that's one of the risk factors for having death in epilepsy, and it's also a risk for having more cognitive issues as well. So, so trying to attack epilepsy early and hard is your best method. If you are a candidate for brain surgery, I certainly recommend getting worked up and trying to do that if you are a candidate. If not, then, and if you've tried a few meds, then certainly VNS should be considered, because it's not a brain surgery. It's a simple outpatient procedure that takes 1 to 2 hours. You go home the same day. So, you don't have to do a lot of workup. You don't have to localize where your seizure is. You don't technically need to have epilepsy monitoring to be done. You could have mixed seizures. So we know a lot of people have epilepsy and also psychogenic non-epileptic spells, which are more psychiatric. And we know that epilepsy patients have a higher risk of having those. And so usually our epilepsy monitoring unit has more patients with non-epileptic spells than epileptic spells. And so if you have a mixed form of epilepsy, means you have non-epileptic, but you really had epilepsy too at one point, or you still have it, still, it wouldn't preclude me from offering it. So when you look at children, 63% of children who are people had fewer seizures, and 8% had shorter seizures, 42% had less seizures, less severe, and faster response. So the benefit, trying more medications doesn't improve seizure rates. So I told you those, if you're going to be intractable, you're going to be intractable. You will, I would say, that doesn't mean you can't reduce seizures. I don't want to come here and say, well, don't try meds. They're not going to work, because there are meds that, since these trials are a little bit superior and help reduce seizure burden dramatically compared to some of the older meds. So, and then many children with epilepsy have reported mental health issues, depression and ADHD, and this can help with that. And then only one third of children will outgrow epilepsy. And seizure control of the VNS continues to improve over time, and quality of life is a big deal. That's something that I think is, if you probably ask patients, it's a much bigger deal than if you ask the physicians, right? When we're seeing you, we're saying, the first thing out of our mouth is, any seizures? You good? How many seizures, right? And we're not saying, how's your mood? How's your thinking, right? We're saying less of that. We're more saying, how are your seizures? Because that's, usually the first thing in our mind to control. And so, I think, we need to probably have more discussions about memory, mood, and thinking. And I would say majority of my epilepsy patients have those issues. And I already know it, and so that they're probably going to have that. And so it's something to target as well, not just target the seizures alone. And patients were 3 times more likely to become seizure-free if treated early with VNS. So, like I said, the more you wait, the more you allow this kindling response to happen, and that makes your epilepsy more difficult to control. So, how VNS works: there's a standard mode. So we turn the vagus nerve stimulation on, and you get stimulated. Usually, we'll stimulate you for 30 seconds, and then you're off for 5 minutes. And that can be, different as we go along. And then the responsive stimulation, we set it to a certain degree where we want your heart rate up or down, or up. When your heart rate goes up by like 20%, then it'll give an automatic stimulation. And we can set it higher for people who want less. And then the magnet, like I discussed earlier, is what you use on your own. When you're having a seizure, about to have a seizure, you can do that. So, again, kind of went over this. It shortens your seizures, decrease the intensity, and then you can use it with MRIs for your brain. You can't get MRIs from hair to hair still. You can get a 3 Tesla MRI or 1.5 Tesla MRI. It's customized to control, so we can set day-night cycles. So some people may have more seizures during the night, or let's say they do some sort of activity during the day, and we can set it according to what the patient needs. So we can change parameters now at day versus night. And we can also do scheduled programming. So let's say that you live 3 hours away from any neurologist and you just can't make it, or you just don't want to visit us. Then we can set it up where it will either, we can use FDA parameters or make our own parameters, and it will go up every certain time period that we agree together. And then you won't even have to come to the office. It'll just stimulate on its own. So again, I discussed earlier, you implant the vagus nerve stimulator usually in your left chest, and some people, have gotten it, they want to have bikini line or whatever, so they'll get it in their armpit. And then you simply send a wire up to your vagus nerve on the left. It's always on the left. And the vagus nerve on the left sends signals through your throat and then to your brain. And so we never do it on the right, typically. The battery lasts between 4 to 10 years, and you usually have a small incision here for where they put the generator. It's not brain surgery, it's a simple outpatient procedure. So the most common side effects are hoarseness, shortness of breath, sore throat, and cough. So the cough I notice more like in the clinic when I go up on the parameters. People will sometimes have a cough. It's not as common. I would say hoarseness is the most common side effect, and sometimes if somebody has early symptoms, I'll delay the speed that I'm doing it. Unlike medications, you don't withdraw from vagus nerve stimulation right away. So let's say you need to get an MRI or it needs to be turned off, then you can just simply make the parameter 0, you turn it off, you can go days without it, weeks even if you really needed to, and then turn it back on. So let's say you get a little bit of hoarseness when it's on, you can take the magnet and put it there, and it turns it off. So you have the ability to turn it off whenever you want. Let's say you don't like that it stimulates when your heart rate goes up and you're about to go sprinting, you can tape it there and go sprinting. You can do your activities, whatever. If it bugs you, you can do whatever activity you want, and turn it off yourself whenever you want to, and you're not going to withdraw. So, unless you do it for like a month or two, yeah, you may withdraw. But so that's one of the benefits again. So it's pretty easy. I can't think of the last time that I had some insurance say that it was not an option for patients, or they denied it, because they know overall it's going to save them money, and they'll do anything to save some money. And there's doctors all over Southern California and the U.S. that are doing this, so it shouldn't be an issue. And there's ways with vagus nerve therapy for connections as well, and there's reps that are there. And what I usually do for people who are interested is before we decide to do VNS, I tell them to speak to one of our reps, and I have Scott who's in Southern California, so I have them call Scott, who then gives them information, and I tell them to ask about the worst case scenario and the best case scenario. Talk to him about these kind of examples. I have my own, and he may have other patients too. So it's a good idea to get fully informed about risk benefit, if anything, before you go into it. And so he really helps in terms of giving all the data information to patients. And then if people want to move further, I also send them to the surgeon just to talk, saying, okay, am I a candidate? And what would the surgery involve directly? And where would it be done? Go over the logistics. And if they're comfortable at that point, that may take a couple months, 2, 3, 4 months, if not longer. Could take a year. And once they're comfortable, then we decide to move forward. So there's community chats, webinars, and the company itself does forums as well, and you can learn more information from all the epilepsy foundations. And then, the fine print side effects. Again, the major issue, I would say, with this is the hoarseness. And some people can get permanent hoarseness, even if you take out the VNS, it can be permanent. That's, in my opinion, the worst case scenario, and it would be pretty rare. But having hoarseness itself, it's usually on the milder end of the spectrum. And if that happens, I usually reduce a few parameters to see if people tolerate it better, and they tend to do well. All right, so any questions? Yes?
Yeah, when RNS versus VNS, like.
Yeah, so that, I think both are good options. So that's really going to come up to you. So if you have a lesion, right, in your brain somewhere, and with RNS, you take a hole, you drill it, and you find out where exactly the lesion is. So now I think they're doing it without epilepsy monitoring, but usually, historically, we've done it with epilepsy monitoring to localize it. And then you attach that RNS device there, and that has an EEG that reads, and that targets that area exactly. VNS, it doesn't matter where your seizures are. So if you could have it here or there, you could have it bilaterally, you could have it generalized. It doesn't really matter. And so RNS would involve a little bit of workup, and would be, I guess, skull surgery, and VNS would be here. So I think both are good options, and so it's really what you're comfortable with in terms of which one you want to go for first. Their rates are similar in terms of benefit. All right, any other questions? Yes?
I heard that the VNS could change your voice. Is that a case in all the VNS surgeries?
Yeah, so the voice is a hoarseness. So that's what can happen, is usually your voice gets hoarse. Not usually, it can get hoarse.
Okay.
So it's not a common side effect, but it is its most common side effect.
Okay.
Right? And so, I've had people that talk like this, and then I go like this, and then they talk like that. So when it's on for like 30 seconds, it can get a little bit different and hoarse. That is the most common thing that I would see. I've had a couple of patients that when they had surgery itself, the surgeon, when they were implanting it, right, either with electrodes or whatever, they had hoarseness after the surgery before anything was done. And so all I did for those people is I waited. And I waited several months, and then I started stimulating. Once their voice improved, I started stimulating at that point, and they were fine.
So the voice would come back to normal?
Right, so if the surgery did it, right? So when you do surgery, some neurologists want it turned on right away. I'm not one of those. I am one of those guys who say, let's see what the surgery did, right? Before I start saying, I don't know if it's a surgery versus me. I want to see you back 2 weeks after you had surgery. So let's give you time to recover, see where you're at. Are you at baseline? If you're at baseline with everything, we're going to start. If you're not at baseline, we're going to wait.
Okay.
And then, so I tend to be a little bit more conservative in that regard, where I want to make sure, because I don't want to be lost like, well, it could be the stimulation. They did turn it on, and maybe you're one of those people who had a low dosage is getting hoarse, and then I got to slow it down anyways, right? So for me, I just want to play it safe and say, okay, are you normal now? You're normal? Now we're going to start.
Okay.
Yeah. Okay, any other questions? Okay, yeah.
So if you said like if your heart rate goes above a certain threshold, you could kind of like disable that function, like if you're going to go running or something, you
Yes.
just tape the magnet to that
Yes.
area?
Yes, you can take
Or if you're going to give a speech or something, you could also do the
Right.
same thing.
So I have a guy who does, public speaking, and he gets a little bit hoarse, and he was also doing like calls all the time. So when he's on that, he would turn it off. And then at one point, he was just turning it off while he's working, and then the rest of the day it was on.
Thank you.
Yeah. Any other questions? All right. Well, thank you so much.